Hey everyone, welcome back to USMLE with Varun. So this is the fifth video of our Musculoskeletal System series, and in this video we're going to study about bone and joint injuries and infections. Let's begin by discussing bone and joint trauma, which represents one of the most common causes of acute musculoskeletal problems in clinical medicine. Musculoskeletal trauma includes injuries to the bones, joints, soft tissues. These injuries can occur due to accidents or sports activities, falls, or high energy trauma. In examinations such as USMLE and NEET PG also, these trauma questions are these trauma questions rarely test only the fracture itself. Instead, these questions will be focusing on complications that occur after trauma. So it is very important that we know about them. So some of the most important complications includes compartment syndrome, fat embolism syndrome, and avascular necrosis. So therefore, when you read a clinical vignette involving trauma, the key strategy is to recognize the injury pattern first. Recognize the injury pattern, anticipate the possible complication, and then identify the correct diagnosis. Recognize the injury pattern, anticipate the possible complication, and then identify the correct diagnosis. So this reasoning pattern is how exactly how USMLE uh, structures musculoskeletal trauma questions. So it is very important that we follow this pattern, recognize the injury trauma pattern, anticipate the complication, and then identify the correct diagnosis. Next, let's review the basic types of bone fractures. Fractures are usually classified based on whether the skin overlying the bone is intact or not. A closed fracture means that the bone is broken, but the skin remains intact. This is the most common type of fracture, whereas an open fracture, also called as a compound fracture, occurs when the broken bone penetrates through the skin. This type of fracture is particularly dangerous because it exposes the bone to infection. So, an open fracture exposes the bone to infection. Fractures can also be classified based on the pattern of the break. For example, transverse fracture runs straight across the bone, an oblique fracture occurs at an angle, and a spiral fracture occurs when the bone breaks due to a twisting force. So, a very important example is that spiral fractures are commonly associated with rotational or twisting injuries, such as those occurring during sports accidents. Certain fracture types are frequently tested in exams, but they occur only in specific clinical situations. So, one example is green stick fracture, which is most commonly seen in children. So, in this fracture, the bone bends and partially breaks, but it does not completely fracture. So this occurs because children's bones are more flexible. Another important fracture type is comminuted fracture, where the bone breaks into multiple fragments. This typically occurs in high energy trauma, such as motor vehicle accidents. A compression fracture commonly affects vertebral bodies and is often seen in elderly patients with osteoporosis. Finally, stress fracture occurs due to repetitive mechanical stress rather than a single traumatic event. So these are frequently seen in athletes and military recruits and runners who repeatedly overload the same bone during training. So stress factors are mainly seen in athletes and military recruits. In addition to fracture type, fractures are also classified based on the alignment of the bone fragments. An angulated fracture occurs when the broken fragments forms an abnormal angle. A displaced fracture means that the bone fragments are separated from their normal anatomical position, whereas an impacted fracture occurs when one fragment of a bone is driven into another fragment. So one fragment of a bone being driven into another fragment, this causes the bones to become compressed together. So musculoskeletal trauma can also involve joint injuries. For example, a dislocation occurs when bones forming the joint are completely displaced from their normal position, whereas Subluxation refers to partial dislocation where the joint remains in contact partially. Complete loss of contact is dislocation, whereas partial loss of contact is subluxation. These injuries often require urgent orthopedic management to prevent permanent joint damage. Not all fractures are so. Before getting into pathological fractures, let's review the different types of fractures. So this is a normal bone, whereas this is a green stick fracture. A green stick fracture is characterized by uh, this green stick fracture is most commonly seen in children, as we have already discussed. So in this fracture, the bone bends and partially breaks, but it does not completely fracture. The bone bends at the side where the impact or force is given, whereas on the opposite side, on the tension side, the bone gets broken. So just like a twig being broken, so green stick fracture also occurs in the same way. That's the reason it's named so. And so the other one is oblique fracture. This depends on the axis through which the fracture line passes. The oblique one, the transverse, whereas an impacted fracture is generally when a bone is broken down, when one fragment is impacted into another fragment. So this can be called as an impacted fracture. The other few other things are torus fracture, oblique displaced fracture, comminuted fracture, multiple fragments, segmental fracture, avulsed fracture, spiral fracture, and linear fracture. Not all fractures occurs because of trauma alone. So sometimes a bone fractures because the bone itself becomes weakened by an underlying disease. So this type of fracture is called as a pathological fracture. Common causes of pathological fractures includes osteoporosis, bone tumors, metastatic cancer, and genetic disorders such as osteogenesis imperfecta. So in exam questions, pathological fracture is usually suggested when a fracture occurs after minimal or trivial trauma. For example, an elderly patient who develops a hip fracture after a minor fall is very likely to have osteoporosis related fracture. So recognizing these clues helps us identify that fracture is secondary to an underlying bone disease rather than purely traumatic injury. Now let's discuss how bones heal after a fracture. Bone healing is a complex biological process that occurs in several stages. These stages gradually restore both the structure and the strength of the bone. The healing process begins with hematoma formation, followed by soft callus formation, then followed by hard callus formation, and finally bone remodeling. So during these stages, hematoma formation, soft callus, hard callus, and bone remodeling. During these stages, multiple cell types participate in a repair process, including osteoblasts, fibroblasts, and chondroblasts. The time required for healing depends on several factors such as patient's age, blood supply to the bone, and stability of the fracture site. So that's the reason why we say that adequate stabilization of the fracture is essential for proper bone healing. So it plays a very key role. Stabilization is the most important thing that needs to be done when a fracture happens. The first stage of fracture healing is hematoma formation. So immediately after a bone breaks, blood vessels within the bone and the surrounding tissues rupture. So this causes bleeding at the fracture site. The collected blood forms a hematoma, which is essentially a localized blood clot. So this hematoma contains platelets, inflammatory cells, and growth factors. These substances, these platelets, inflammatory cells, and growth factors, these substances initiate the healing process by stimulating inflammation and recruiting progenitor cells that will eventually differentiate into bone-forming cells or osteoblasts. So therefore, uh, although the hematoma represents an injury response, it is actually an essential step in initiating bone repair. So, hematoma formation is an essential step in initiation of bone repair. So, after the inflammatory phase, the healing process progresses to the formation of a soft callus. During this stage, fibroblasts and chondroblasts migrate to the fracture site, and these cells produce fibrous tissue and cartilage that bridge the gap between the broken bone fragments. So this structure is called the soft callus. Although the soft callus stabilizes the fracture, it does not yet have the mechanical strength of the bone. So this stage usually lasts several weeks as the cartilage gradually begins to be replaced by bone tissue as a cartilage. So this soft callus stage lasts for several weeks. In the next step, soft callus is gradually replaced by bone, particularly woven bone. So this process occurs through endochondral ossification, which is the same process that is uh, used during bone development in childhood. So osteoblasts begin depositing new bone matrix, and this new bone matrix, whatever is formed, it is called as the hard callus. So this newly formed bone is typically bovine bone, which is stronger than cartilage, but still, even though it's stronger than cartilage, it's still structurally mature. So at this stage, fracture becomes significantly more stable when compared to the stage at which there is soft callus. So, although it is significantly stronger than soft callus, it is not yet fully strong as normal bone, and full strength gets restored after the bone remodeling phase. The final stage of fracture healing is bone remodeling. So, during this phase, the woven bone produced during the hard callus stage is gradually replaced by a mature lamellar bone. So osteoclasts resorb excess bone while osteoblasts deposit new organized bone matrix. So this process restores the normal architecture of the bone and aligns the bony trabecule along the lines of wherever mechanical stress is being given. So bone remodeling depends on the kind of mechanical stress you give. Bone remodeling may continue for months or even years after the initial fracture. So eventually, the healed bone regains much of its original strength and structure. It resembles a normal bone. Now we move into one of the most important orthopedic emergencies. It is the compartment syndrome. So compartment syndrome occurs when pressure increases inside a closed muscle compartment. Compartment syndrome occurs when pressure increases in a closed muscle compartment. So these compartments are surrounded by uh, rigid facial layers. That these facial layers are are usually designed in such a way that they cannot expand easily. So these compartments are surrounded by rigid facial layers that cannot expand easily. Whenever swelling or bleeding occurs inside the compartment, the pressure rises and compresses the blood vessels that supply the muscles and nerves. So, as a result of all this, as a result of increase in pressure, as a result of compression of the blood vessels, what happens is tissue perfusion decreases and the muscle begins to suffer from ischemia. So, common causes includes fractures, thrust injuries, tight casts or bandages, and severe soft tissue swelling. So this condition is extremely important because it represents a surgical emergency. If compartment syndrome is not treated quickly, it can lead to permanent muscle damage and nerve injury. So compartment syndrome is definitely a surgical emergency. To understand compartment syndrome better, we need to look at the underlying pathophysiology. So muscle compartments are enclosed by inelastic fascia. So when trauma causes bleeding or swelling within the compartment, the internal pressure begins to rise. So as this pressure rises, the small blood vessels supplying the muscles become compressed. This reduces blood flow and oxygen delivery to the tissues. So without adequate oxygen, muscle cells begin to undergo ischemia and eventually necrosis. So nerves are also highly sensitive to ischemia. You can suffer irreversible damage. Nerve damage is irreversible. So this is a very important thing to remember. So if once the nerve injury or nerve damage occurs, it is irreversible. So uh, restoring perfusion is a uh, key thing, is something that needs to be done as an emergency procedure. So permanent damage can begin to occur within approximately 6 hours, which is why rapid recognition and treatment are very critical in compartment syndrome. The clinical features of compartment syndrome are classically remembered using the 5 Ps. So these include pain, pallor, paresthesia, paralysis, and pulselessness. However, the most important and the earliest sign is severe pain with that is out of proportion to the injury. So another key clue is pain with passive stretching of the muscles within the affected compartment. So the key clues in this compartment syndrome includes severe pain that is out of proportion to the injury, and the other one is pain that occurs with passive stretching of the muscles that are enclosed within a affected compartment. So as the condition progresses, patients may develop numbness, weakness, and eventually loss of pulses. So in exam questions, the most sensitive early clue is usually severe pain during passive movement of the affected limb. If compartment syndrome is not treated promptly, it can lead to severe complication called Volkmann ischemic contracture. So this occurs when prolonged ischemia causes muscle necrosis and fibrosis. The affected muscles, particularly the forearm flexor muscles, become shortened and scarred. So as a result, the patient develops a permanent contracture deformity of the hand. The hand may assume a claw-like position, like we see in this image, a claw-like position, because the flexor muscles are permanently shorted in this condition of Volkmann ischemic contracture. The hand shows a deformity like a claw-like position. This complication causes irreversible functional impairment, and it also highlights the importance of treating the compartment syndrome early. So this is a complication of untreated compartment syndrome. So this is a late complication. Another important complication of trauma is fat embolism syndrome. So this condition occurs when fat droplets from the bone marrow enter the bloodstream after fractures of long bones. It most commonly occurs after fractures of femur or pelvis, which contains large amounts of bone marrow fat. So these fat droplets, once they enter, they travel through the circulation and get lodged in pulmonary microvasculature. So when uh, they get lodged in pulmonary microvasculature, this leads to pulmonary embolism and eventually infarction. So that's a life-threatening complication. The classic clinical triad includes respiratory distress, neurological symptoms, and petechial rash. So all these symptoms usually appear within 24 to 72 hours after injury. So patients may present with features like shortness of breath, confusion, and small petechial hemorrhages on skin. Petechial hemorrhages, confusion, and shortness of breath. So recognizing this triad of shortness of breath, petechial hemorrhages, and confusion is very important in identifying fat embolism syndrome. Next, we will discuss avascular necrosis. Another important complication, another most important complication that is associated with bone injury is avascular necrosis, which can also be called as osteonecrosis. Avascular necrosis occurs when the blood supply to a bone is disrupted. So, without adequate blood flow, what happens is osteocytes within the bone die, leading to progressive bone weakening. So, over time, the structural integrity of the bone collapses, which leads to joint degeneration. So, certain bones are particularly vulnerable to vascular necrosis because they rely on limited blood supply. So, I just think of a bone which doesn't have enough collateral circulation. What eventually happens is when one artery or one blood vessel is damaged, what happens is because of lack of collateral circulation, what happens is there is loss of blood supply to that particular point of the bone. What eventually happens is there is occurrence of necrosis because of avascularity. So this is called as avascular necrosis. The most commonly affected site is the femoral head, and other vulnerable bones includes scaphoid bone and talus. There are several conditions that interrupt the blood supply to the bone and cause avascular necrosis. Trauma is a major cause, particularly fractures or dislocations that damage blood vessels supplying the bone. Other important causes includes chronic corticosteroid use and excessive alcohol consumption. Certain systemic diseases also can also predispose to vascular necrosis, such as sickle cell disease. So we have a mnemonic. The first thing is corticosteroid use, alcohol abuse, sickle cell anemia, trauma, CAS. So other risk factors includes radiation therapy and decompression sickness. A very classic exam scenario. So we can identify this case of vascular necrosis with a typical pattern of patient who has been on long-term steroid therapy and develops progressive hip pain due to vascular necrosis of the femoral head. The femoral head is the most common site of a vascular necrosis. Blood supply primarily comes from the medial circumflex femoral artery. If the artery is damaged, such as during a femoral neck fracture, the femoral head may lose its blood supply. As a result, the osteocytes die and the structural integrity of the bone weakens. Patients typically present with progressive hip pain and reduced range of motion. Over time, collapse of femoral head can occur, leading to secondary osteoarthritis of the hip joint in case of avascular necrosis. Besides the femoral head, there are several other bones that are particularly vulnerable to avascular necrosis. The scaphoid bone in the wrist is one of those examples. So after a scaphoid fracture, the proximal fragment may lose its blood supply, and this scaphoid fracture is extremely common after wrist injury, uh, you know, fall on the flexor surface of the hand. Another vulnerable bone is the talus, which can develop vascular necrosis following ankle trauma, whereas femoral head is the most common site overall. These bones are susceptible because they have limited collateral circulation. So, limited collateral circulation is the highest risk factor for occurrence of vascular necrosis at any bone inside our body. Therefore, when trauma affects these bones, the disruption of blood flow can easily lead to ischemia necrosis, and this can eventually progress to vascular necrosis and secondary osteoarthritis. In clinical questions, vascular necrosis is often suggested by a combination of symptoms and risk factors. So patients usually present with chronic joint pain that gradually worsens over time. So a history of trauma, corticosteroid use, alcohol abuse, or sickle cell disease might be present. Imaging studies may show subchondral bone collapse and progressive joint degeneration. So, if untreated, vascular necrosis can lead to severe joint destruction and secondary osteoarthritis. So, recognizing these patterns early allows timely diagnosis and intervention to prevent permanent joint damage. Now, we move into bone infections, beginning with osteomyelitis, which is extremely high yield. So, osteomyelitis refers to an infection involving the bone and bone marrow. The infection can travel through several mechanisms. So one common route is hematogenous spread, where the bacteria travel from the a distant site through bloodstream and then it might seed the bone. So another route is direct inoculation, which may occur after trauma, like in cases of open fractures. So we have discussed that there are open fractures and closed fractures. Open fracture is characterized by loss of skin barrier. So whenever a fracture uh, occurs and the bone fragments just pierces the skin and exposes the bone and the fractured segments to the external environment, it is called as an open fracture. So direct inoculation can occur from these open fractures, and direct inoculation can also occur during orthopedic surgeries. So in some cases, infection spreads from nearby soft tissues into the bone. So the most common organism responsible for osteomyelitis overall is Staphylococcus aureus. So this infection leads to inflammation, bone disruption, and disruption of blood supply within the affected bone. In children, the most common form of osteomyelitis occurs through hematogenous spread. So in this situation, bacteria enters the bloodstream and from another site of infection, and then it might travel to the bone. So the fracture most commonly gets lodged in the metaphysis of the long bones where the blood flow is usually slow and turbulent. So because of this unique vascular arrangement at the metaphysis of the long bones, bacteria can easily accumulate and also begin multiplying. Common sites that are affected because of hematogenous osteomyelitis includes the distal femur, proximal tibia, and proximal humerus. Therefore, when a question describes a child with fever, bone pain, difficulty bearing weight, children don't tend to express or localize pain. So, the most important feature we have to observe in children is rejecting to carry weight. So, rejecting to just walk by themselves or uh, because they just can't localize the pain. We have to identify these signs when thinking of them or when looking at a child. So, hematogenous osteo. So in all these, child presenting with fever, bone pain, and difficulty bearing weight, hematogenous osteomyelitis of the metaphysis should be strongly considered. Different osteomyelitis uh, causes includes organisms like and the Staphylococcus aureus, Salmonella, Pseudomonas, and Epidermis. So, whatever these organisms might be. So, these organisms depend on the patient's risk factors. The most common overall pathogen is the Staphylococcus aureus. However, certain clinical conditions are associated with specific organisms. For example, patients with sickle cell disease are particularly more prone to osteomyelitis that is caused by Salmonella species puncture wounds through athletic shoes or through so, uh, just direct contact with the ground. So these are often associated with Pseudomonas aeruginosa infections. Infections involving prosthetic joints or orthopedic implants are commonly caused by Staphylococcus epidermidis. So exams frequently test this association between specific risk factor and the causative pathogen. Staphylococcus is the most common overall. Salmonella species uh, is most commonly the involving organism in people with sickle cell disease who might be present in osteomyelitis. Uh, Pseudomonas aeruginosa occurs in patients who undergo puncture wounds through athletic shoes and infections involving the prosthetic joints or implants are commonly caused by Staphylococcus epidermidis. Acute osteomyelitis typically presents with signs of infection and inflammation. So patients commonly develop localized bone pain, fever, swelling, and redness over the affected area, and also limited limb movement. So in children, osteomyelitis may present with limping or a refusal to bear weight on the affected limb. So because the infection can rapidly destroy bone tissue, early diagnosis and treatment is extremely important in cases with osteomyelitis. So, if untreated, the infection may progress to chronic osteomyelitis, or it can also spread to the surrounding tissues. So, it needs to be taken care of. The pathology of osteomyelitis involves intense inflammation within the bone tissue. So, when bacteria infect the bone, neutrophils and other inflammatory cells accumulate at the infection site, and this leads to increased pressure within the bone and reduced blood supply. As a result, parts of the bone may die and become necrotic. So, two important pathological terms are often tested in exams. So, the first is sequestrum, which refers to a fragment of dead bone. So, sequestrum is a fragment of dead bone that has become separated from the surrounding living bone, whereas The second one is involucrum. So the second one is involucrum. So which refers to new bone formation of new reactive bone. So that forms around the infected area. These structures are so these structures like sequestrum and involucrum are characteristic for uh, chronic osteomyelitis. When acute osteomyelitis is not fully treated, the infection might progress to chronic osteomyelitis. So in chronic infection, inflammation persists for a long time and leads to progressive destruction of the bone. So patients may develop chronic bone pain, persistent infection, and sometimes drainage through the sinus tracts that extend from the bone to the surface of the skin. So because necrotic bone fragments trap bacteria, chronic osteomyelitis can be very difficult to eradicate completely. In chronic osteomyelitis, the structural architecture of the bone becomes significantly altered. So the dead bone fragment, called as the sequestrum. So this sequestrum acts as a reservoir for bacteria. Meanwhile, the surrounding bone attempts to repair itself by forming new reactive bone. And so this newly formed reactive bone is also called as involucrum. However, this new bone often surrounds the infected area rather than just replacing it. So this just surrounds the infected area because the infection becomes trapped within the bone. So because it's just trapped, it's not being exposed to the other bones. So long-term treatment with so because the infection becomes trapped within a bone, it's there's a possibility that it might infect the entire bone, might spread to the joints, or it might spread to the surrounding soft tissues or hematogenous seedling matter. So anything might occur. So the thing is that long-term treatment with antibiotics and sometimes surgical removal of the infected bone may be required in those cases of chronic osteomyelitis. Next, we discuss septic arthritis, which is an infection involving joint space. In septic arthritis, bacteria invade the synovial membrane and multiply within the synovial fluid. So, this multiplication usually causes rapid joint inflammation and destruction of the articular cartilage. This septic arthritis commonly affects joints like the knee, hip, and shoulder. Septic arthritis is usually considered a medical emergency because cartilage damage can occur very rapidly if the infection is not treated promptly. So septic arthritis should definitely be dealt as a medical emergency. The organisms responsible for septic arthritis vary depend on the patient population. So the most common organism overall is Staphylococcus aureus. However, in sexually active young adults, septic arthritis may be caused by Neisseria gonorrhoeae. In elderly or immunocompromised patients, Streptococcus species are the common causes. So, if a question mentions a young adult with joint pain and history of sexually transmitted infection, might suggest gonofocal arthritis. The diagnosis of septic arthritis requires joint aspiration and synovial fluid analysis. So, the synovial fluid in septic arthritis is typically purulent or cloudy. So laboratory analysis shows a very high white blood cell count, often greater than 50,000 cells per microliter with a predominance of neutrophils. So bacterial culture may help, help us identify the causative organism. Because septic arthritis can rapidly destroy the joint cartilage, so mm, because rapid damage is a possibility, early diagnosis and treatment with antibiotics and joint drainage are really essential. Now we'll discuss tuberculous osteomyelitis, which is a chronic bone infection which is caused by Mycobacterium tuberculosis. So unlike acute bacterial osteomyelitis, so osteomyelitis or tuberculous infection usually develops slowly and progressively. This is a slowly and progressively growing infection. So the infection typically spreads to bone through the hematogenous dissemination from primary pulmonary tuberculosis infection. So because tuberculosis produces chronic granulomatous inflammation, the disease progresses gradually and often causes destruction of bone over time. So the most commonly affected sites includes vertebrae, long bones, and the weight-bearing joints. So whenever a question mentions chronic bone pain combined with systemic symptoms of tuberculosis, uh, it should raise a suspicion for skeletal tuberculosis. One of the most important forms of skeletal tuberculosis is Pott's disease, which refers to tuberculosis infection of the vertebral column. So in this condition, the infection typically begins in the vertebral bodies and may spread to the adjacent intervertebral discs. So as the infection progresses, it might cause progressive destruction of the vertebrae. So this progressive destruction can eventually lead to spinal instability, like deformities, and sometimes this can also end up with spinal cord compression also. So a classic complication is the development of kyphosis, which results from collapse of the vertebral body. So whenever collapse of vertebral bodies occurs, what happens is kyphosis. Because Pott's disease is the most common form of skeletal tuberculosis, it is uh, frequently tested in all those exams. So it is really important that we know about this Pott disease. Tuberculous bone infections typically develop gradually or slowly, and it may initially produce very mild symptoms, but patients often present with chronic back pain, which gradually worsens over time. So, systemic symptoms of tuberculosis may be present, like the systemic symptoms that might be seen in tuberculosis infection of the bone might be fever, night sweats, and weight loss. So, a radiological image may reveal vertebral collapse, bone destruction, and sometimes you can also see paraspinal abscess formation. Uh, uh, so this paraspinal abscess is definitely a characteristic feature. So, characteristic feature of tuberculosis is the formation of something called as a cold abscess, which refers to an abscess that develops without the intense redness and warmth that is typically seen in bacterial infections. So, whenever we think of a bacterial infection, whenever we think of septic arthritis, what generally comes into our mind is a red, swollen, tender, warm erythematous appearing joint area. So, but this is entirely different. So, in tuberculosis infection of the spine or Pott disease, what happens is there might be possibility of cold abscess formation. So, whenever there's cold abscess, it's definitely a characteristic feature for tuberculosis infection. So, it's called as a cold abscess because there's nothing like that intense redness and warmth that is seen in typical bacterial infections. Another important form of bone infection that occurs in patients with diabetes mellitus, uh, particularly in the setting of chronic foot ulcers, is the diabetic foot osteomyelitis. So, diabetes can cause peripheral neuropathy and reduced blood circulation to the feet. So, because of this, patients may develop ulcers that they do not notice or they just don't care about treating it promptly. So these ulcers become infected and the bacteria might then spread from the skin to the underlying bone, producing osteomyelitis as you can see in this image. So there's just uh, peripheral neuropathy occurring. So whenever there's peripheral neuropathy, what eventually happens is reduced blood supply to that feet. So this reduced blood supply eventually leads to development of ulcers, and when ulcers occur, there's exposure of uh, the soft tissues and the bone eventually to external environment. So first, if the infection spreads from the skin to the underlying soft tissues, then to the underlying bone, and when this bone is involved or when this bone is infected, this produces osteomyelitis. So these infections that occur in diabetes are often polymicrobial because I mean they involve multiple different bacterial species because they enter through the skin. So poor wound healing and reduced immune response in diabetic patients makes these. infection is really difficult to treat. So diabetic foot osteomyelitis is extremely difficult to treat. In exam questions, like uh, what we what we're going to solve or what we're going to practice, diabetic foot osteomyelitis is often suggested as a classic scenario. So the patient typically has long-standing diabetes, presents with a chronic foot ulcer, and this foot ulcer fails to heal. So there may be exposed bone, deep infection, or we can also see foul-smelling discharge in some cases. So common organisms that are involved includes the Staphylococcus aureus, Streptococcus species, and various gram-negative bacteria. Severe infections might require aggressive treatment, like including surgical debridement or even amputation in extremely severe cases. So recognizing this pattern is important because diabetic foot infections are a major cause of morbidity in diabetic patients. So it's just hell for a diabetic patient to get an ulcer and then develop diabetic osteomyelitis. Before we finish the video, let's review some of the most important complications that are associated with fractures. So, for example, compartment syndrome presents with severe pain that worsens with passive muscle stretching. Fat embolism that typically develops after long bone fractures and presents with a triad. There's a characteristic triad of petechial rash, neurological symptoms, and respiratory distress. So, another important complication is avascular necrosis, which occurs when blood supply to the bone is disrupted. So, recognizing these clinical patterns helps us identify the complications really quick. Another strategy for solving questions is to associate specific pathogens with particular clinical situations. So, for example, Staphylococcus aureus is the most common cause of osteomyelitis overall. Patients with sickle cell disease commonly develop osteomyelitis that is caused by Salmonella species. Puncture wounds through athletic shoes are often associated with Pseudomonas aeruginosa infection. And finally, infections involving prosthetic joints are commonly caused by Staphylococcus epidermidis. So, all these associations between the risk factors and pathogens are frequently tested. So, uh, just memorizing these will definitely help us solve most of the questions. Now, let's compare osteomyelitis and septic arthritis, since these two conditions might appear similar in some clinical scenarios. So, osteomyelitis is an infection of the bone itself, whereas septic arthritis is an infection within a joint space. So, osteomyelitis typically causes localized bone pain, while septic arthritis causes severe joint pain and swelling. In septic arthritis, synovial fluid analysis usually reveals purulent fluid with very high leukocyte count, normally greater than 50,000 per millimeter cube. Whereas uh, the joint fluid might be normal in those cases with osteomyelitis because the septic arthritis rapidly destroys cartilage. It would require immediate treatment. So the most important complications of osteomyelitis is bone necrosis and that of septic arthritis cartilage destruction. So when evaluating a patient suspected of having a bone infection, a structured diagnostic approach is really helpful. So the first step is to evaluate the patient's symptoms and identify risk factors for the infection. Next, we can do laboratory tests such as BSR, CRP, and WBC count, which can indicate inflammation. So imaging studies including MRI, X-ray might reveal bone destruction or soft tissue involvement. Finally, microbiological cultures or bone biopsy may be needed to identify the causative organism. So early diagnosis is essential because untreated bone infections can eventually lead to permanent damage. So to summarize the key concepts from this video, uh, musculoskeletal trauma can lead to serious complications such as compartment syndrome, fat embolism, and also vascular necrosis. Osteomyelitis is most commonly caused by Staphylococcus aureus, although specific pathogens are associated with other particular conditions. So, like we have discussed, sickle cell disease is mostly associated with Salmonella species. Prosthetic implants is mostly associated with Staphylococcus epidermidis. Yeah. So, septic arthritis produces purulent synovial fluid with a very high WBC count, and this requires urgent treatment. Tuberculosis infection of the spine causes Pott's disease, while diabetic foot ulcers may lead to chronic osteomyelitis. So understanding these patterns helps us to quickly identify those trauma and all those infection-related questions. So it's extremely important that we try to understand how pattern recognition needs to be understood in musculoskeletal system. In the next video, we'll get back to you with a module on bone tumors and tumor-like lesions. Before ending the video, I would like to request all of you to subscribe and keep supporting. This lecture series is provided free and is open access for everybody on an open access platform like YouTube. So there's nothing like a paywall or a mandatory fee. So if you find it useful and wish to support its continued development or just help us improve the quality, build a team, voluntary contributions are really welcome. So I'd like to request anyone who would be happy if, to welcome any of those contributions. So you can pay with the link that is in the description and also pin on the screen. You can pay with any of these payment methods that I've mentioned. So I'll get back to you with more exciting videos on other systems, specifically musculoskeletal system. We're going to end it in three more videos. One video on bone tumors and bone lesions. The other one is related to spine and back disorders. The other one is related to metabolic disorders, and we'll finally end with a video on all those miscellaneous topics that are related to the rheumatology. So this series is started with a motto to end burnout and empower active learning. So where there's a market with a lot of study resources, and we just put ourselves into endless passive lectures. The most important thing that we need to do is just sit down with our book, open our book, read, read it by yourself. You might go wrong at the beginning, but eventually when you read, what happens is you tend to remember it for a long time rather than just passively watching lectures or reading those slides that are available on the market. I don't advise you to watch even my videos. So these videos are designed in such a way that helps you understand what's really important, what's actually tested, and how it's actually tested. So this is just like a brief brush up. So this series is designed with a motto that you would just briefly understand what a topic is, what are the points that are actually covered under the topic, and then sit down with your book, read it from the first ever word to the last word related to that particular topic which are going to solve on that particular day, and then solve questions, review them, and when you just watch a lot of lectures, what eventually happens is you would not be getting time for the most important thing, solving questions. So this is designed with a motto that you just try to understand. This would help you understand what's actually important. So I hope it's helping you. I'll get back to you with more exciting content, more helpful content. So before ending the video, I'd like to request all of you to subscribe and keep supporting and keep waiting for the upcoming lectures. Thank you.